47%, excuse me, on April 2022 to 50% by May 31st of 2023. This is the fun part, our PDSA cycles and if this really worked. So first we joined our social determinants of health task force at our hospital. So that really helped propel a lot of this in our interventions. We standardized screening, performance security, 6-month interval. We also then started working with our EPIC team. We use EPIC as our electronic medical health record. We were able to get monthly data reports and completion of those. So I feel like that's really important. I needed to know who was completing it, who wasn't, and I even was able to drill it down to which medical assistant was doing it, and really engaging those people to help get the screening completed. We then utilized our health maintenance topic is really just a visual and a reminder, and the next slide will show you what that looks like in our EMRs. Automating assignments of patient-entered questionnaires. There's stigma surrounding asking these questions. So assigning a patient-entered questionnaire to where the family has the option to fill it out prior to the visit, to have that information when you're not asking those questions, was, I think, a really good strategy for our patients. We also leveraged EMR documentation of resources. So what happens is that it then gets loaded. If they screen positively, all the resources that we have available will then get loaded onto their after visit summary, so they have that information. And then for this one is huge. I think we've heard about engagement and what that means with this collaborative to continue to engage your clinicians, your patients, and the staff is a real, and for them to understand the why we're doing that, I think this is really huge with social determinants of health. And then we have a target tracker. This is like my favorite thing ever. It just, again, serves as a reminder and a visual because, with surveillance testing and with diabetes, there's so many things we have to remember to do as clinicians. And the more you can leverage and having the visuals for your staff, I think is huge. A tracker that we can just, do chart prep and click the box. And again, it serves as another reminder. Who do we screen? So we utilize the health maintenance topic to then figure out how we can screen these patients and what frequency, and we have a best practice alert. So we then chose all active patients seen in the last 3 years or scheduled in the next 6 months. The frequency is every 6 months. That was our recommendation from the task force that we joined. And again, we wanted to be mindful of the changes in economic circumstances, but reduce the burden of screening. So utilizing this health maintenance topic in EPIC was a big win for us. Yeah. Okay, great. So this is what the health maintenance topic looks like. This is just a visual. It's actually changed. I wanted to see specifically my diabetes surveillance labs along with some other metrics that we were, tracking for U.S. News and World Report. But again, this is the, you can see right here, the health maintenance topic, the food. Oh, I'm so sorry. That's okay. Good recovery. So this is the food insecurity health maintenance topic. When it was due, things that are overdue that will float to the top. Obviously, there's logic in EPIC that runs all of this in the background. The frequency is every 6 months, and then if it was completed, the date it was completed. So, and this to the right, the patient entered questionnaires, we assign those by visit types. So every new and return diabetes visit type gets assigned a patient entered questionnaire through my chart. And again, for those of you that just entered, we use EPIC as our electronic health record. It's available in English and Spanish. It automatically adjusts if we have Spanish documented as their preferred language, so they will get that. You can also flip it to an EPIC.
And then these are the questions, the 2 questions, the hunger vital sign that's asked for food insecurity. Would you mind advancing to the next slide? This is not working. Thank you. Our results, the fun part. I'll draw your attention to the increase. Obviously, that's what we wanted to do. As of May 2023, the percentage of youth with diabetes screened for food insecurity increased by 44% based on our efforts. From May of 22, we had a baseline of 27% and we increased to 71%. I'm happy to report that we are now at 80% of screened positively. So next slide. Oh, it seemed to work. So conclusions, the application of this methodology again has enabled, I think, our center to do wondrous work and move that needle and improve outcomes. And then leveraging the EMR tools. I've learned a lot about EPIC, and I've learned if you push hard enough, and I have a team that's doing that, you can really leverage that. So I encourage you all to do that. Next steps, how do we make this sustainable? How do we advance? How do we move forward? So we want to continue with education and training to promote sustainability. I feel like that is always something you have to have a pulse on. You have to be following up with your team because without them, it's not possible. Collaboration with our food navigation program. This is a resource that we've had, I want to say within the last year or so, but it's actually a food navigator that will contact them directly. We give resources, we tell them, here, read this, but do they actually do it? So we have a food navigator, which is awesome, and they will call the family, they will reach out to them, and they will make sure that they know where to find food in their neighborhood, what local programs they could be or they could benefit from. And then our next plan is to use the same approach with transportation and housing. So we just started, we're in the beginning phases of that because that's definitely additional impacts, not only food, but we see all of the social determinants of health affecting our type 1s and type 2s. This would not be possible without a huge team. So I want to say thank you to all of these people on these slides. Our QI team, many of them are here today. Our food insecurity task force, our medical assistants, I praise them continuously. They are the pulse. They keep everything running. And then our food navigation pilot program. Without all of them, this would not be possible. Thank you so much. Do we take questions? Okay, 1 minute for questions. Okay, great. Yes. I'll have you repeat that again, just for people on Zoom.
To what do you attribute the remarkable difference in the prevalence of food insecurity between the type 1 and type 2 patients?
I'm not sure how to answer that, but I would say access, and I guess just looking at our baseline, but our access, especially for the type 2s, they have what I have seen is they've experienced a lot more socioeconomic concerns and issues that have prevented them from getting the access to the food resources. Mm-hmm. And the resourcing and knowing how to get the resources, and the education with food and how to nourish their body. I feel like that's another thing we spend a lot of time with, and educating about food and resources and what that does to your body. Any other questions?
Perfect, thanks. Okay, our next presentation is by Blake Adams, and the title is Establishing Social Determinants of Health Screening to Improve Pediatric Diabetes Patients' Outcomes. And we have the presentation here.
Do you want me to take the clicker
Oh, yes.
if it's working?
Let's try it.
Okay. Hi, everybody. I'm Blake Adams. I'm the site coordinator for Bonheur Children's Hospital in Memphis, Tennessee. I'm also a clinic nurse, so I have those two perspectives. Today, we're going to talk about our QI project, basically initiating social determinants of health screening. Our mission at Bonheur is to partner with families and support them in ways to help best manage their diabetes care. And despite the existing research correlating social factors and the suboptimal glycemic control, our clinic wasn't screening for SDOH. So we were doing nothing as far as screening goes for our diabetic patients. So our aim was to screen just 10% of our total patients with type 1 and type 2 with SDOH. Screening based on a set of specific criteria, and we were going to do it from June of 2023 through August of 2023. So a short amount of time, over like 2 months. So we met bi-monthly with a multidisciplinary team, and the team consisted of me, Grace Nelson, our PI. We had a nurse practitioner in our group that met with us, and our medical student, who was really the reason why we kept it small is because she was on her break and was able to help us collect all the data and really help with the process in general. We decided to focus on screening patients who'd been diagnosed for at least 6 months, who had an A1C greater than 9.5, a lapse in care with at least 6 months, or the anniversary of their diagnosis date was around 3 months of when they were being seen. The items explored in the screening was food insecurity, transportation barriers, household financial strain, social isolation, and both physical and mental and emotional abuse. And through the collaboration, we connected with the University of Michigan and borrowed their Partners of Care survey. And we tweaked it a little bit to just for our population, but it basically is one survey. It's just broken apart. 0 to 10-year-olds are filled out by the caregiver, and 11 to 17 is filled out by the patients themselves. So, and I brought it with me if at the end of this anyone wants to look at it. It's a good survey. PDSA cycle 1. So we met with our team and we established the guidelines. We also met with staff to get their opinion on how they thought flow should go. So since we'd never screened before, we wanted to figure out how we were going to hand out the screens and get them back efficiently. The medical student screened 2 providers, and we did it for 2 weeks ahead of time. And she gave that list to our clinic scheduler, who created little folders based on their age, and then gave that to the medical assistant, and she handed them out to the patients at the clinic appointments. And at the very end, there was a basket in the med room that the providers then put the survey in that was filled out, and then the medical student could pick those up and then collect all the data. We did, in our first 2 weeks, we did 14 completed surveys with 4 positive and 3 referrals made. None of the families elected for an optional social work consult. So we were kind of like, so the ones that were positive didn't want to have social work come see them. So we decided we were going to convert the final survey question and make it to where the interventions and resources and referrals wasn't necessarily optional. It was just a statement like, we'll offer resources if appropriate. So in PDSA cycle 2, we changed it. If needed, our team will give information and resources that can help. Let us know if you have any questions. So we did that for 2 weeks. We did 19 completed screens with 12 that were positive and 10 referrals were made. We also decided after this PDSA cycle, we were going to add a provider only section just to make it easier for us to determine like what was done when they did screen positive. So whether it was like a referral was made or a resource was offered, we just added a little section at the bottom so we could check a box. The provider could check it so that way we could follow up better to see what was being done. We also added all the resources that luckily our social worker had into our online system. It's like a shared drive. I don't know if y'all use something similar, but that way the nurses had access to it during clinic and could print it. If at one of our other locations, social work wasn't available, they could just print out the resources that were needed. Let's see, in PDSA cycle 3, okay, so we added the provider only section, like I said, and added the online resources, and just reminded providers to make sure and chart it clearly in the chart, just so we could follow up and make sure what was being done. We did that for 2 weeks and got back 19 completed surveys with 6 positive and 5 referrals were made. After this, we decided to just remind them again, like make sure and fill out that provider section just so we can continue to follow up. We added a list of available resources to the survey itself, just so the families would actually know like what if they said yes to one of the questions, what would even be available? What could we offer them if they were screening positive? Hopefully to pique interest, encourage honesty, and just reduce hesitancy. And in our final PDSA cycle, we screened again for 2 weeks. We had 13 completed surveys, 3 were positive and 3 referrals made. After this, after meeting with Ori as well, we kind of decided we were going to simplify our criteria in order to continue expanding the SDOH screening. And we were just going to center on the patients with A1C greater than 9.5. We had a lot of like criteria, and we decided to focus on that for in the future. So we successfully increased our SDOH screening from 0 to 4.3%. 51.6 of our eligible patients completed the screens, and 38.5 of those were positive. And 84% of patients that were screened positive were offered social work referrals or resources. Based on, some of the results out of it. So the total percent of non-Hispanic white patients was just under 40, and of those, a little over 20% were positive screens. And then the non-Hispanic Black patients was about 60% of the screens. And out of those, 75% were positive. If you look at the amount of like the percentage total that were on technology, the percent positive they were less likely to be on technology if they're screening positive. We also looked at like A1C. The patients that were negative had a lower A1C versus screens that were positive tended to have a higher A1C, also more ER visits and hospital visits. Reasons for the survey just not being completed. It wasn't that families refused or somebody didn't want to fill it out. It was more, they no-showed the appointment in general, so we couldn't give it to them. They also, the second most common reason was they rescheduled the appointment. So once the medical student had identified like 2 weeks ahead of time, all the patients that we could screen, the patient still had time to cancel, no-show, et cetera. And then just incomplete screens returned or just screens not administered. That was actually a pretty small percentage of why we didn't get a screen back. So in conclusion, though we didn't reach our goal of 10%, we felt good about the amount of patients we did end up screening in that short amount of time. And it really just made it seem like it's a really beneficial thing that we want to add and just extend to more providers to keep the project going. We are anticipating changing to Epic in October of next year, which after listening to your talk, it sounds like there's going to be so many more reminders. Like we will be able to program it into the EMR, which will make our whole process easier. So in the meantime, we got a year, so we got to figure out what we want to do in the meantime. We're going to focus on 2 new providers and try to just screen the elevated A1Cs is our focus. And those are my references. Any questions? Yeah. I had a couple of numbers too. So we had 126 eligible patients, 65 completed the surveys, and 21 referrals were made. So 25 were positive, 40 were negative. And then the average age of screened patients was about 12 and a half. And we screened about 75% of the patients we screened were type 1, and then 25% were type 2. So. Yeah. Right. So that's we're hoping to start in the new year. So we're going to wait past the holidays because it feels like everyone and anyone is taking off are going to be out. So it's kind of hard to start a new project over the holidays. But the idea would be to maybe expand our team a little bit. The medical student still wants to be involved. She just can't be as hands-on. But also if the criteria changes, and we're going to focus on 2 new providers who are excited I feel like that's the one thing we focused on in the last year, just in general, is it's been Grace and I for so long since we joined in 2020. We're trying to make our group a little bit bigger because we can't do it all. So like we invited the rest of the clinic to join like monthly QI meetings, which we weren't doing before. And I feel like now we have more people interested in helping with little projects. So that's been a nice thing. Yeah. So the screen that we use, the University of Michigan screen, they'd already kind of established like who needed to fill out which part and based on their age. So we just went along and did it the exact same way they kind of did.
If you want to do that, let us know.
So no, it's the medical assistant hands them the survey. So it's a piece of paper that they write down and they fill it out in between the time when the nurse checks them in and then they're waiting on the provider to come in and see them. And the provider, once the visit, from what I understand, once the visit's kind of done, they'll review over it. And then if resources or referrals need to be made, they'll do it then. So they have time to sit there with it and fill it out themselves. And it's not like anybody's going through it with them until the very end once it's filled out. Yeah.
All right. Our next talk is by Dr. Ruth Weinstock, and it's on screening for social determinants of health in adults.
Thank you. So yes, we'll switch to adults now. And first I want to thank the team and particularly Beth and Joe who are here today for all their hard work on this. So our goal was to screen adults for social determinants of health at their routine visits, to provide resources and social worker support for those who tested positive, and ultimately to determine if there's any reduction in social needs and does that associate with improved outcomes after referring our patients to social work. So we're going to look at data today over 8 months from August 2022 to April 2023. We also use EPIC, which has we used 8 questions that are in EPIC that relate to housing, food, finance, transportation, and securities. Our LPNs also during the rooming process were collecting this information, and a positive screen was defined as any positive response to any of those questions. And anyone with a positive screen was offered a referral to a social worker. The demographic and clinical characteristics I'm going to show you are from the EMR, and predictors of social work referral acceptance we assessed using exploratory multivariable logistic regression. So these are the people who we screened during this 8-month period. So again, this is adults. I'm showing type 1 and type 2. The type 1 is in the middle there. You can see that we had a pretty good screening rate. 86% of our type 1s were screened. Not surprisingly, the mean age in the type 1s is younger than the type 2s by about 22 years, about half female, more African Americans in our type 2 population, which reflects the demographics. And in terms of our type 1 adults, 40% had public insurance. In terms of our type 2s, it's 70% have public insurance. So it's much higher, which is expected because of the Medicare, the type 2s being older. And CGM use in our type 1s was 84% in this population, and a bit over half were using pumps. So to summarize our results, the majority who screened positive had more than one material need. So 13.4% of our type 1 screened positive, a little more than that, 16% of our type 2s. And the majority of those with type 1, 56%, had more than one material need. 60% of the type 2s. Our African Americans were more likely to screen positive than our white population. 32% versus 12% in our type 1 population. And adults with public insurance, and we put Medicare and Medicaid together in this, were more likely to screen positive than those with private insurance. But for our type 1s, 21% of those with public insurance screened positive, but 8% of our patients with private also screened positive. And not surprisingly, adults not using a pump were more likely to screen positive than those using a pump, 17 versus 10%. And this just shows you the different food insecurities. Again, the middle is our type 1 patient, looking at food insecurity, transportation needs, financial resource strain, and housing. Again, we referred these people to social work who had resources that they could offer. We do have a patient assistance program for medications, for example. We have local food banks. There are different resources that are offered. Now, how many accepted a social work referral? So 25% actually accepted the social work referral. And there was no difference by sex, race, ethnicity, age, CGM, or pump use. 78% who accepted a referral to a social worker had more than one social need. And those with public insurance were 3 times as likely to accept a referral to a social worker than those with private insurance. Adults with transportation needs, and again, we have a lot of rural patients who have trouble getting to us, were 2.3 times more likely to accept a referral compared to those who did not. And those with housing needs were also over 2 times more likely to accept a social worker referral compared to those who are not. And these are just the numbers, but it's basically, it was 25% for both type 1 and type 2. So to conclude and where we're going with this, material needs are common in our adults with diabetes. So one thing that we've already done is try to improve our screening. So now we're offering confidential screening that they can fill it out on paper without the again asking the questions. And anecdotally, it looks like our numbers are higher now. More people are saying that they're having these insecurities than I showed you here. And we want to reduce the barriers of acceptance to social work referral. So we did meet, I didn't go over all the PTSA cycles. We had lots of them, tried lots of different things. But one of the things that we realized is that the LPN says to a person, do you want referral to a social worker? That might have, that word social worker may have a stigma. And so we've now asked them to say, would you like assistance? Leave out the word social worker. And then, so there are some changes that we're making that we hope will increase the social work referral. Also, if our patients now say that they have food insecurity, because you know, this information goes into Epic, that's how we generate all these reports. If they have don't have enough food to eat at that time, like that day, in the next few days. As of last week, thanks to Beth and Joe working on this, we have now the ability for them to meet with the social worker, hopefully, but even if they refuse that, dietitian to help them pick out a box of food that they can take home with them, because we now have a food pantry in our building. So that, in addition to referring them, of course, to their local food pantry for longer term needs. So we hope that that will increase the number of people who can be helped. And we just figured out a way, we hope this will work because it just started, but to track who actually got food and see, you know, how, if that made a difference. In addition, we have an outpatient pharmacy in the building run by our institution. And we do have a way to help people who are having trouble affording their meds to get what they need. So we're using that as well. And what we want to do, and hopefully we'll be working on over this next year, and we'll be able to hopefully report next year, determine who accept the social, if the people who accepted the social work referrals did that versus those who didn't, did it make a difference? Like, you know what, is there a difference in their in the screens for social determinants of health, and is there a difference in their glycemic outcomes, A1C, CGM metrics, depression? We do PHQ screen on most people. I would also love to know if it improved their quality of life, because I think that's probably one of the most important things, but we don't have an automated way to do that yet. So I think that's, so that's the end, and be happy to answer any questions. And thanks to our team for doing this.
Just yes. No, I was going to say actually, stand with your word in terms of food insecurity. Have you observed any differences between type 1 and type 2, or just are you just focused on?
Well, I do have a slide there that showed the difference in prevalence.
And the A1C.
Oh, yeah. So we don't have the A1C data yet. Yeah. Hopefully next year we're looking at pre-post for that. But we're doing it on everybody. So we didn't, it's easier, our whole clinic. So it's just part of the rooming process now. So we're not focusing on just high A1Cs. Again, this is adult, it's different than peds, but so it's part of the rooming process, just like doing the PHQ. It just goes into Epic.
So you refer everybody to the social work. And that's refer, how does that work? Is that done the same day? They have to make an appointment to back?
Yeah, so that's the other thing that we're working on. We want to improve accessibility at the time of the visit. I should have said that. I meant to say that. We have now a full-time social worker at our clinic, and our goal is for the patient to capture them while they're there. Now, if we see a lot of patients at once, so that isn't always possible, but that's our goal, is to try to have her see the patient at that visit, because we find if they have to come back, doesn't happen a lot of times, majority of times maybe. I don't know the exact percent, but so that's a goal. And if we miss them, she'll try calling them. But now we're going to try and we have a really nice resource sheet that our educators have put together with the help of the social worker. Actually, it's a whole team effort, and resources in all the different counties that we serve, as well as, we can tell them about this, the ability to get some food. There's also a grant that the institution got, and Beth knows more about this than I do, but fresh produce, this just started last week also. And if their A1C is over 7%, once a month, we can give them a bag of fresh produce. So that's, I forgot where that grant came from. It's not a grant from us. So we're in a building that has primary care in it, the food pantry. So this food pantry is not just for our diabetes clinic. So we're in a new ambulatory care building, and it has primary care and us. And so everyone in the building has access to this food pantry and this fresh produce.
It's your food pantry.
Yeah. Central New York food pantry. Yeah. Yeah.
Thought about the acceptance of the social work, and I think that's forward. I'm just curious, in terms of having that food pantry with your recent experience, do you think there may be some stigmas related to accepting parents? I think we have a similar thing, and I haven't seen that. It's been very successful, but I'm wondering if that might be.
We have a setup actually where our food pantry is located four floors down, and our RD actually moved out the setup, the clinic, so the patient actually doesn't go down into bed, so they're not seeing going.
And we just started to do this part, so
Actually, accept the RD and the food pantry for the middle itself.
How do you link your patient with transportation needs to telehealth?
so that's a good question. So by link, you mean, so we offer, so what we do is we offer a telehealth visit if they cannot make in person. And clearly transportation needs is one of the huge reasons for that. So that is something that we offer across the board. So if someone calls and says, I want to cancel my appointment because I don't have transportation, the phone people are supposed to say, and usually do, well, we can switch it to a telehealth visit. So we do that across the board. Yeah, we haven't, right. So that's what we do. But when people, problem is when they make the switch to telehealth, we don't have a way in the EMR, we're not recording why they made the switch to telehealth, So, it could be transportation. I had someone just switch to telehealth because his wife came down with COVID yesterday, and do I still want him to come in? And I said, I think we'll do a telehealth visit. So, I mean, but that's not recorded anywhere, in the EMR. So, but I think the most difficult one is going to be, because we'll look at the different insecurities as housing. I mean, that's like, there are things we can do for transportation. There's some things we can do for food, and for financial is tough too, but getting people housing is really tough. Thank you.
My pleasure. So we have two more talks. Now is Dan DeSalvo and his work with Rebecca Butler, and this is on the REACH registry using EMR-based tools to improve outreach services. Thanks, Dan.
Thank you, Francisco. And I am humbled and honored to be sharing this work on behalf of my colleagues and friends at Texas Children's, led by Salome De Tutu and Becky Butler. This is our extra care cohort. So a little bit about our now decades-long history in trying to identify who are patients in need of extra care and then providing it in a proactive manner. Started with our risk index for poor glycemic control, which was developed by David Schwartz, one of our psychologists, where at the point of diagnosis, a social worker would do kind of a check-in with families that were based on SDOH screening and identifying who is needing extra care to prevent DKA and obtain optimal glycemic control. We then brought on a dedicated extra care social worker, in addition to 3 other social workers we had in clinic, whose main purpose is to support these families on their T1D journey. Later in 2019, we developed a risk index for DKA, which was more based on some other parameters within the EMR that were automated and dynamic in nature. And then over the course of the past few years, we've been able to kind of develop increased automation within the EMR. That's what I'm going to share with you today. So this is a peek at the risk index for DKA, again, developed by David Schwartz, who's a psychologist. And this was published a couple of years ago in Clinical Diabetes. And what this consists of is 3 main dynamic variables within the EMR. You can see these over here. The number of DKA events they've had in the past 2 years, what their most recent hemoglobin A1C is, and whether or not they have public health insurance or that they're uninsured. And then based on those parameters, there's this dynamic shift in their risk index for DKA or RIDKA, where it changes over time, where a higher RIDKA score represents a very high risk of having a DKA event or suboptimal glycemic control. So this 4-tiered model allows us to really kind of tailor, streamline, and triage care to patients in most in need. And we can actually see this on the left side of Epic on that little character storyboard, where it shows their RIDKA score, and you can see how it changes over time. You can even click on the simulator and look at what if their A1C improves or they have a DKA event, how does their RIDKA score change? So some examples of interventions that have come out of this initiative, including having a 2-week post-DK follow-up visit by that extra care social worker, but then also dynamically in between clinic visits, meeting the patients where they are to facilitate diabetes education, prescription management, and psychosocial care. And then also we use this passport. It's probably similar to what some of you have mentioned before. We identify what needs to happen at that clinic visit for this day, with whether it's screening or doing a PHQ-9 screen or visiting with a social worker, dietitian, CDCS. We have the RIDK score front and center on that so that our extra care social worker can meet with that patient and their family if indicated based on their RIDK score. And then this also allows us to help with appointment follow-up, transportation, telemedicine connection, and all these other dynamic processes to facilitate care. Francisco, I need your help with moving forward. So this is a little bit of an overview of our, if you go back one slide for me, our really robust diabetes registry that's been a decade in the making. We had this parent registry of all of our diabetes patients of all types, and then filter that down by type 1 diabetes. And then from there, we had these child registries where we can identify different groups who have different needs. And what I'm going to focus on today will be the REACH cohort. And to take us in a little bit more there, the first segment from the diabetes registry, and you can go ahead and advance if you're able to, is our HELLO cohort, which stands for Help for Youth with Elevated Glucose Levels to Improve Outcomes. These are kids with sort of a moderate to high RIDKA score that's above 6. And then a subset of that is this REACH cohort, who are truly the most in need, with this resources and care to improve health outcomes, where they have an RIDKA score above 9 or a little bit lower DKA score, but a recent DKA event. That helps to really mobilize our team and then triage that care to those youth and their families in most need. I'm not going to focus on the no-show cohort today, but that's another kind of child registry of our overall diabetes registry within Epic. I think I still need your help. So this is a screenshot of a dashboard that for these youth who are part of the REACH cohort, the care team can access this dashboard and see who are the new patients who are part of this registry, what are the tasks that are due for them. You can kind of filter into a dashboard that I'll show on a subsequent slide, and then look at some quality improvement measures, all within Epic, where these, these clinicians live and work, maybe not play so much, but they live and they work, and they can see the task at hand and see if the care that they're providing is resulting in improvement. And if you advance one, we use a flow sheet that allows us to kind of look at who's within the registry, make them active, so we can have a smaller segment of these people in the REACH cohort to really kind of focus the care for. Provides the reasons why. As you'll see, we use a lot of these flow sheets in part for these discrete data elements, so we can track how we're doing over time. This is a look at that kind of, once you hone into the REACH registry, you get this new dashboard where each line represents a patient. And within each line, you can see many different clinical care variables. So what is their RIDK score? When is their next clinic visit so that you can help to arrange transportation? Are they using pump or CGM? What is their A1C? You can see their most recent care coordination note if you hover over the patient. And then we have a 5-domain SDOH screener in Epic, probably similar to what I think, Ruth, you guys use at SUNY Upstate, where in this case, it's housing, transportation, food insecurity, financial resource strain, and health literacy. And then based off of that, you can have a sort of a mental model of what the patient's and family's needs are. We do food insecurity screen at every in-person clinic visit. We do this 5-domain screener with an annual social work visit once a year. So these data are available and made ready to the clinical team. This is the outreach that the extra care social worker, or community health worker, or population health nurse uses to kind of assess what the needs are and then track the care that they're providing. Next slide. And they also will document the goals that were established, the outcomes. One, it helps to streamline their documentation, but just as importantly, helps us track the data over time to see if the care that we're providing is resulting in improvements through QI measures. So a few conclusions and future directions. One, we're still learning that Epic tools can really be leveraged to help to facilitate our work in a more nimble way that ultimately, hopefully, will help to result in improved health outcomes for youth and family on their T1D journey. And using these EMR-based tools helps us to automatically track outcomes. We look forward to sharing some of those results with you at future meetings. And the next step, and this will be a subset of that REACH cohort for those who are truly at the highest need, where we have hired a community health worker. And through that program, they're going to be focusing on 5 main goals with appointment management, access to healthy food, supporting diabetes technology and access, and trying to reduce those barriers that we all encounter with the care that we provide for youth and their families, making sure that they can sort of map out the public benefits, access these resources, and then finally helping out with that transition of care to adult provider, which can be challenging, and helping to sort of navigate them through that process. So thank you guys all very much. And again, I want to say a word of a few thanks to the amazing extra care team who's doing this work. Again, led by Dr. Salome DeTutu and Becky Butler. Kelly Timmons is our Epic analyst who really makes this work happen. She's incredible. And we applied for and received a Helmsley Diabetes Care Innovation Award, which helped to provide some resources to make this work happen. So thank you. Yeah, so, it's the dashboard. To kind of step back, creating the diabetes registry was the first step. And we used sort of like a diabetes flow sheet to identify who has type 1, type 2, et cetera. Once that registry was built and all the other discrete data elements within the EMR, creating the dashboard actually didn't take very long at all. It is a Epic-based tool that's available. So if you have a really great partner with an IT Epic builder, it's there. I would say that it probably took a matter of days to weeks, actually. So not long at all. Once you can identify who that cohort of interest is, having the dashboard is not that difficult. And we use it for other populations as well. Yes. Yeah, so it's a good question around how do we identify who is type 1 and type 2, who's responsible for that, and how do we track that in Epic? So as opposed to using the problem or ICD-9, 10 codes, et cetera, we use a diabetes flow sheet that anchors all of our clinical encounters. And the very first line of that is what type of diabetes do you have? And, because that, sometimes if the antibodies are negative and type, especially in pediatrics, it may start as type 1, end up being MODY or type 2. So that is what sort of anchors which diabetes type they have, which is what then allows that registry to take place with all the subsequent variables of interest. So that's what we use we call it the diabetes flow sheet. Yes. It's a good question. The question is can our flow sheet at Texas Children's be transferred to other people in Epic? We are very happy to share it. We've shared with many people in the collaborative. We've also learned from others. I come from a place of a lot of humility because this has been a journey with all of you guys. But in terms of actually pulling it from Epic, I don't think you can actually do that, but you can take what we've had and use it, in a way that's local and helpful for you. And I have screenshots of it on my computer right here. So if anybody's interested, email me or find me after this. I'm happy to share. Yes. Mm-hmm. Yeah, yes. So it was, so the question was around how were these initial RIPGC and RIDKA scores developed? And it was sort of an iterative process that was more of he's both clinical and research. So it was using sort of a lot of research methodologies to develop these tools and to validate them. The next step is going to be actually incorporating SDOH, these SDOH screeners that we have. We've already found, and Don Buckingham is working with us on this as well, that people who screen positive for food insecurity actually carry a higher risk of DKA. And Michael, you may have seen this in your work as well. So we're actually incorporating food insecurity. As we have more of this 5-domain answers available, it's likely that some of those other domains will actually factor in that model for predicting who's at risk for DKA and or rising A1C as well. Yeah, I mean, you're teeing up Michael and the NICH program so well here, but I can take it one of two ways, right? There's I think we all as clinicians can often identify who that is. I think the academic answer is that it's driven by social determinants of health and who has access to food, transportation, diabetes technology, who has health literacy, what the family situation is. And so what we've learned is that those who are affected by social determinants of health specifically have a higher risk for severe DKA with a pH lower than 7 or bicarb less than 10 and multiple DKA events in a year. So, and it ultimately probably takes not taking insulin. And there's many reasons why that can be. Interestingly, we found that PHQ-9 screening and or depression diagnosis was not, at least in our model, associated with an increased risk of DKA as an independent variable. So I think it's those. I mean, it probably is. It's certainly a factor for some, but at least in a model at 3,000 people with diabetes, it didn't show up. That I think that we certainly see that lived out in the lives of our patients. So, you know, I can't say for sure, but at least in the model, it didn't show up as an independent variable. Well, thank you, guys. All right, thank you.
And our last presentation is titled "To Contract or Not to Contract," and this is on the NICH program, Paying for NICH to Address the Social Drivers of Diabetes Outcomes by Michael Harris. Thanks.
So just, you go back to the title. Just a quick editorial. As you can see, we use the term drivers, not determinants. Determinants is absolute. Drivers is dynamic. And what you'll find if you work in this space and just this discussion is it's an incredibly ever-moving kind of issue for our families. And so we've talked about screening. What I'm going to talk about today is a program that we developed to intervene in the social drivers of health, specifically in diabetes. It's called the NICH program, Novel Interventions in Children's Healthcare. If you were at ADA, we actually were one of the winners of the inaugural ADA Innovation Challenge, and that was really exciting. Yeah, that was great. And what was more exciting for me, and hopefully for you all, is that there were 60 entrants into this innovation challenge, and we were the only one that was in the space of social drivers of health. So the fact that we made it all the way through that, got in the finals, and then won means people are paying attention. Okay. Is this working or not? So I just want to give a shout out to Helmsley Charitable Trust, who funds big part of our research endeavor in terms of identifying the effectiveness and the outcomes. It's part of the theme here, and so you'll see some of the outcomes here. Next. So this is what we do really well as a healthcare system, right? We provide a lot of what, a little bit of how, and very little why. This is the extant approach to social drivers of health as well. So we start applying the same thinking of how we typically apply or how we typically provide medical care to these social drivers. What NICH is, next slide, please, is we turn that on its head. We are interested in the social ecology. We are interested in the live experience. That's where we spend our time and energy, and that's where the intervention occurs. Next. So what do our results look like? So this is just a handful of our results from, one more time, from our type 1 population. You can see remarkable changes, right? We're changing or reducing the cost of healthcare significantly. These are almost all publicly insured youth who are part of this program. And from the year prior to the year during, they're reducing healthcare costs by $30,000. These are all type 1 kids. And then we're reducing another $15,000 to $20,000 after they are discharged from the program. We're cutting admissions in half. We're cutting DKAs in half. And then A1C, people may look at this and say, well, you know, your kids are still hovering in the 10s. Most of the kids that are in NICH have A1Cs that are 14 plus and have had 14 plus for years. So to move it 1% or more is just a remarkable kind of thing. Next. So this program has an incredible amount of challenges. And once again, I love the discussion around screening. Well, the discussion gets even more complicated when you start talking about interventions. And so the challenges are many, but I want everybody to leave with here with not just thinking about the challenges, but that we can overcome the challenges. We got to think smarter about how we're going to address these drivers. So the first one is that everybody knows this is diabetes is budget dust in healthcare finance. Okay. We see kids who've had 12 DKAs in a year. We've had kids who've had 40 DKAs over the course of their lives. And that doesn't even touch the top 1%, the top 2% of spenders in healthcare. Things like short gut, things like CF, end-stage renal disease. So this doesn't get people's attention. And so if you're going to work in this space around the dollars that drive our healthcare costs, you have to go after the most costly. And that was our strategy, because we're going after the big spenders. We're going to move the needle on the money. We're going to get people's attention, and then we're going to start radically changing healthcare. Next. This is another really important thing to think about when you're talking about interventions, is that there's a lack of ownership over this population. So who is responsible for this population? Is it endocrinologists? Is it diabetes clinics? Is it social workers or psychologists who are embedded in diabetes clinics? Or is it the social service systems? Is it Department of Human Services? Is it Child Protective Services? Who is responsible? Both point the finger at each other, right? The problem is not diabetes, so it must be the social service system. Well, these kids have diabetes, it must be the medical system. So this is another piece that if you're going to start thinking about intervention in this population, you have got to create a model where you demonstrate value to one or more of the stakeholders. And we went after the healthcare system to show taking care of this population results in really positive outcomes and value for the healthcare institution. Next one. And then this one is endemic throughout our healthcare system, is that medical centers are set up to provide medical care. They are not set up to provide care around social drivers of health. And so you have to learn how to build an infrastructure to support this. Once again, I hear comments about food pantries in healthcare settings. That's part of this, right? You have to learn how to shift your thinking away from how the medical model works to how do you provide support for people's social challenges within an institution that really is geared towards and steeped in the history of providing medical care. So this is our current service area. We're out throughout the entire Oregon area. We're in mostly the Portland metro area, but Central Oregon and Bend, on the coast in Coos Bay, down south around Eugene. And so we're kind of stretched across Oregon, but then we also have NICH at Stanford and UCSF. It's been baked into the budget at both of those places. So this can be done in complicated healthcare settings. That's another positive message you should leave with about when you start thinking about intervening in the social drivers of diabetes outcomes. It can be done even in the most complex. And if anyone wants to, I don't know, is anyone here from California, but that is one of the most complex healthcare systems. I thought Oregon was a mess. California, just the Bay Area itself is just, the players are changing constantly. The rules are changing constantly. It's very, very hard to navigate, but we've done it. Next. So the million-dollar question is, aren't people like falling over themselves to get this program, right? So you saw the catchment area, Oregon, Project, and the Bay Area. That's it, okay? I've been all over the country giving talks. People want to hear about NICH. People want to hear about how we do this, right? People are really interested. And then what happens? I don't get the call back. All of a sudden, nobody's interested. It's not that they're not interested, but think back to my last slide around some of the challenges. In principle, it sounds awesome. I want to save $30,000 per patient. I want to move the needle on A1C. I want to cut hospitalizations in half. But where the rubber hits the road is that means you have to put a square peg in a round hole, and that scares people. So that's some of the uphill challenges we have with healthcare systems. Next. So what we did, and this presentation is basically a retrospective qualitative review of what were some of the things that moved the needle on contracting, both within Oregon and the Bay Area, okay? We initially thought we're going to reduce costs, okay? And that really is going to get everybody's attention. That's going to get people to line up. Next slide. And so we did this through reducing avoidable hospitalizations. So what's the challenge with that? How do you take credit for things that never happened, right? So you have somebody who had 12 DKAs in 6 months, right? And then you swoop in and all of a sudden there's no DKAs. How do you say that that was your work that did that? People want to talk about regression to the mean. People want to talk about all kinds of factors that drive some of these health outcomes, okay?
I think it's on the third floor, so I just
we had to kind of pivot a little bit because people were not just lining up to reduce costs in healthcare. They didn't buy it, and they were making these other arguments. So next slide. So then we started to go down the quintuple aim of healthcare put out by the IHI, And we started to hit on some of these other things. Well, it's not just reducing costs, it's improving health. It's improving care. Do we have an audience for that? Are there people out there, stakeholders that are invested in diabetes care where they can see reductions in A1Cs, that better care is being delivered, better access to technology? What about providers, right? That's the fourth of the quintuple aim. It was the triple aim, then the quadruple aim, and now the quintuple aim. How does this population impact the rest of you, right? In providing care, it burns people out, it costs systems money. And then how about the impact on health disparities? Next slide. So this is the roadmap that we found in retrospectively reviewing the contracts that we were able to establish. And it wasn't just about the money, but oftentimes it did come back to the money. We had to get smarter about how we were able to craft the message, right, around the changes that we were impacting. So avoidable hospitalizations, we did that, right? Cut those in half. Cut the cost of care from the year prior to the year during and then after pretty significantly. That data is in the can. What about taking pressure off the ED or the ICU? Okay. This is a big problem for large medical centers that have a lot of people coming into the ED. They can't handle a bunch of kids or adults or young adults that are in DKA sitting in their ICUs, right? And their EDs. And so what we were able to do is keep these patients out of the ED, keep them out of the intensive care unit, freeing up beds for more critically ill young people, right? Also freeing up the ED a little bit, because I don't know about your ED, but I went down there the other day and it looked like a war zone. We had people in beds along the walls, no room. We always get these messages in Epic that say, we're at capacity, do whatever you can, right? All hands on deck. So this became for our institution a really important piece of what we do. How about reducing length of stay? So having been in this business of NICH for about 10 or 12 years, I started to learn about healthcare finance. And what I learned, and you may already know this, I didn't know this, is that most hospitalizations, the return on investment happens within the first 48 hours of a hospitalization, and then it dramatically drops off. So what happens is if you have a patient in a hospital and after 48 hours, you've already recouped all the dollars you're going to get from that hospitalization, and it's just going to go down dramatically. So this is the most expensive hospital stay that you'll ever have because you're not getting any return on your investment. And so hospitals want to reduce length of stay in these kids. It also frees up beds for higher acuity patients, and it frees up beds so you can bring in patients who maybe are not publicly insured. Okay. So this was a big change for our program under the hospital org, because they started seeing for each event that a child in NICH came in, we reduced length of stay by half. It translated into $5,000 to $10,000 per event savings for the hospital, plus the money that was incurred by bringing another person into that bed. Decreasing no-shows. I work in the diabetes center. One day a week, I see patients one after the other. If they don't show, guess what? I still get paid. How cool is that? Right? It's horrible. And it's what's broken about our healthcare system. And so these are the patients that don't show. And we're still getting paid despite that. And so what we were able to show the institution is we reduced no-shows, late cancellations, so that we had clinics that were full, rather than having doctors, nurses, educators, other healthcare professionals sitting idly by. We built in ability to bill out G codes through our insurance, which then was very attractive to people because rather than an alternative payment method, they were able to get credit from CMS by billing a G code for the service line. And that has transformed our ability to get reimbursed by Medicaid. This is a big one, physician burnout, quality of life. Once again, this is the population you worry about. This is the population that keeps you up at night. This is the population that you spend an enormous amount of time doing everything but doctoring and nursing patients, right? You're a lawyer, you're a social worker, you're a friend, you're everything but a healthcare provider to these people. And so the amount of stress results in turnover. If you look at the cost of turnover of physician, it's somewhere around $500,000 from beginning to end to onboard a new doctor, okay? Those are huge dollars lost that institutions don't want. So we were able to make the case there. Health disparities and health inequities are priorities right now. There's money there. And so once again, if you're working in the space of social drivers of health, this is the place to capitalize on that, to show that your institution is doing this stuff, and they'll start throwing some money at it. Pretty much every institution now has a chief health equity officer, right? And so that's a really important piece of this. And then foundation support. This is a place to get philanthropy from inside your institution. It's a no-brainer that people see value in changing the social challenges that people have to improve their health and their livelihood. Next slide. So this is the leadership team, but more importantly, the next one, this is our team. So we have one of the most diverse teams at OHSU. Oregon is one of the whitest states in the United States. 2% of the population in Oregon is Black. And 50% of the kids in NICH are kids of color. And so it was really important for us, if we're going to work in this space, and I heard that conversation earlier about having a workforce that matches the patient population, is that we committed ourselves to having a patient or a workforce that matched the kids that we work with. And many of these people speak Spanish, so they're bilingual, bicultural, and a lot of them come from lived experiences. So that was another thing we had to change. And that's part of what healthcare doesn't do well, is if you're going to hire people with lived experience, you have to change the way you bring people in. So we're giving credit instead of college credit and master's degrees credit, we're giving credit for lived experience. And we were able to change internally what our institution valued in terms of how we paid these people, because we pay them actually quite well, but it was an uphill battle because there's no template for this, right? You have a bachelor's degree, you get paid this. You have a master's degree, you get paid this. You have a doctorate, you get paid this. And so that was a lot of time and energy, but it was an important lift in terms of if you're going to work in this space. So thank you, and I'll take any questions. Is this cool? Yeah. Not just because I developed it, but I think it's just really neat. I mean, it's really neat to be able to see like all the incredible work the exchange does around health inequities, and some of the stuff that Osagi presented is like, that's gold for us in terms of moving the needle and actually intervening in. Yeah, so the question is what are the actual interventions that we do? So the interventions are all evidence informed, and it's a conglomeration of things, but a lot of it is skills training and behavior management change. And the interventionists are not psychologists, they're not social workers, they're not nurses. So they're not delivering medical care or mental health care. They are intervening in systems. So oftentimes some of the So some of the interventions have nothing to do with the family or the child, and some of the interventions have everything to do with the family and the system, but they're all informed by